Hello, I'm Dr. Mark Nowar, and I am a gastroenterologist, a clinical gastroenterologist. The use of electrogastrography up until now has been relegated in looking at diseases such as gastroparesis or dyspepsia, or even in the field of reflux. However, a very large, rapidly growing field is the challenge that we need to meet with regard to obesity, or the bariatric challenge. And does electrogastrography actually have a role? When we think about obesity, again, this is another very complex chronic disease. There are significant comorbidities. So when we talk about type 2 diabetes, and we know that diabetes plays a significant role in gastroparesis, it becomes even more compelling to think about electrogastrography. In addition, obesity is creating an increasing economic burden on the healthcare system. There are many accepted therapies, including dietary modification and physical exercise, in addition to pharmacological management, of course, surgical therapy, and now what is becoming very, very strong and popular is the endoscopic management of bariatric disease. However, this is still a very difficult clinical problem because long-term maintenance becomes a big issue. Some of these issues involve patient selection, as well as predictability of results, and then also avoidance of complications. And so the question is, does electrogastrography have a potential role? When we talk about electrogastrography, and we talk about the obese patient or the bariatric patient, one of the interesting questions is, do obese patients have the same gastric motility as the non-obese population? And this is a very important question because in order to determine subsets of disease and therefore predicting how therapy may be better for one patient versus another, it becomes important for us to understand, do bariatric patients have the same motility? In the normal population, we expect to see 80% of patients with normal electrogastrograms. This is what research has shown us. And we expect to see approximately 20% variability. We've begun looking at the bariatric population, and what's very interesting is we're seeing a lot of dysmotilities. In particular, what you can see here to the left-hand portion of this slide is what we call a mixed dysrhythmia, and you'll notice here that there is increased tachygastric rhythm above the population-based normals, as well as increased bradygastria with a poor 3-cycle per minute activity. This is what we call the mixed dysrhythmia. There's also tachygastria, where you see predominant high cycle per minute activity, as you see here in this particular diagram. In addition, there can be changes that are created just by the introduction of different devices to treat obesity. In particular, here's an example of what happens when a balloon is inserted into a patient to assist with weight loss. Traditionally, everyone has assumed that the balloon causes weight loss by causing obstruction to the stomach, when in fact what we see with the balloon in situ, the patients who develop the nausea that is quite severe or moderate, as well as vomiting, have instead what you see here, a significant bradygastria, where the balloon is causing distension of the fundus, which fires off the fundic receptors and slows down motility, resulting in poor 3-cycle per minute activity and therefore the inability for these patients to eat without becoming ill. We can also see some other interesting changes, and electrogastrography appears to be developing a role. In particular, if we stay with the balloon patients for a moment, here's an example of a patient whose balloon was in situ, who developed nausea and vomiting, and we performed an electrogastrogram, and instead of seeing the typical bradygastria pattern here, you see that we see some increased 3-cycle per minute activity after the water load, indicative of instead more of an obstructive pattern. When performing an endoscopy on this patient, we in fact found pyloric ulceration, which was compromising the pyloric channel outflow, therefore explaining why the electrogastrogram was so different. Once we treated this patient and were able to demonstrate resolution of the pyloric ulcer, with the balloon still in place, we repeated the electrogastrogram, and now we go back to the normal balloon in situ type pattern where you see mostly tachygastria with poor 3-cycle per minute activity. The value in this particular case is that electrogastrography was able to help us look for other diagnoses that allowed this patient to keep the balloon in place and therefore continue weight loss over time rather than removing the balloon because of symptoms. What is the future role in bariatric therapy, therefore, for electrogastrography? Here are some of our challenges. First of all, the mechanism of action will need to be further investigated because we'll need to see what changes occur with regard to the electrogastrogram and hormonal relationships, as well as gastric motility itself. This will then enable us to identify the subtypes, and once we can identify subtypes, then perhaps we may actually be able to decide which device or which therapy, endoscopic therapy in particular, may be better served in a given patient based upon the electrogastrogram, as well as this may also lead to improved patient outcomes. The electrogastrogram likely holds the key to that subtyping. And again, what we're just beginning to do now is perform these obesity population-based normals so that we know what normal is, as well as then decide what subtypes of motility and accommodation exist in responsive therapy. And what is interesting in some of the preliminary data that I can share with you is that you'll recall I mentioned that in the normal non-obese population, we see 80% normal 3-cycle per minute activity. And what we're finding, in fact, in the obese population is that their normal is more like 80% abnormal and only 20% normal 3-cycle per minute activity. This will enable us, therefore, to correctly subtype patients once therapy is entertained.